Hi there, my name is Priya Krishnan. I'm a consultant anaesthetist, and this is my presentation on pre-eclampsia and eclampsia for the MECU revision course 2024. I just want to take you through a recent case that we've looked of a lady we've looked after who was gravida 3, para 2, age 28. She was a Caucasian female, 35 weeks pregnant with a BMI of 31. She had a history of epilepsy, but only had her last seizure at age 10 and wasn't on any medication for it. She's also a type 2 diabetic on insulin and metformin, and her blood sugars were stable. She'd recently been seen at a local hospital at 34 plus 3 weeks with 2 high blood pressures, BP of 151 over 100 and 142 over 90, with 1 plus of protein, a normal CTG, but she refused treatment and wanted to go home. So she had an SHO review, she had some bloods, so started on some oral labetalol and sent home with twice weekly BP checks and weekly PET bloods. What would we have liked to do in this woman who presented with high blood pressure and query PET? We would have done an A to E assessment and a quick history, and I will talk about this later in the talk. And we would have also specifically looked at certain aspects in her maternal assessment. So we would have tested her reflexes to see if she had any hyperreflexia or brisk reflexes, any clonus at her ankle for more than 2 beats. Had she got any history of flashing lights or persistent headaches, any other symptoms such as epigastric pain or nausea and vomiting, which are typical of PET, any difficulty in breathing or shortness of breath, which may be consistent with someone with pulmonary edema, and any lack of reduced urine output or severe hypertension, which would also be indicative of someone with severe pre-eclampsia. We'd do a fetal assessment, and also we would look at her blood results. So is there any rise in her serum creatinine of more than 90? A rise in her ALT, so liver function, over 40 or twice up the upper limit of the normal range, or a fall in her platelet count of less than 150. We may also do a platelet growth factor level if it was available. So what are the risk factors for this lady in our area? So in the Chatham area, babies, we work in a poorer demographic where babies born to women in the most deprived areas are twice as likely to be stillborn. They're at 73% excess risk of neonatal death, and their risk of mortality is doubled. With regards to this lady's epilepsy, we need to be aware of the most recent Embrace report, where epilepsy contributed to 9% of deaths. And so therefore shared decision making with all the specialties involved is really important. So an early neurology review alongside obstetrics and midwifery and anaesthetics, and adherence to the medication. So we need to reinforce to the patient that they need to stick to their meds. In terms of diabetes, that also poses a risk, with perinatal loss 4 to 5 times higher than the general population. And if the patient's high blood pressure goes untreated and they're feeling unwell, that contributes in the Embrace report to 4% mortality. So this lady had a lot of risk factors. Other risk factors that we need to think about in other patients would be chronic high blood pressure, previous PET, any evidence of CKD or chronic kidney disease or any autoimmune disease. But without these, this lady still had a significant number of risk factors that we should have been mindful of. So just wanted to highlight some key messages from the recent Embrace report, where epilepsy and sudden unexpected death in epilepsy are key. And you can see these in these 2 infographics. It also gives you a depiction of how PET contributes to mortality, and as does epilepsy. So it's really important to update yourself with the most recent Embrace report. So what happened to this lady? Well, her husband woke up to her fitting in the morning, the following morning. So he rang the ambulance, and the hospital emergency service, emergency helicopter service, arrived, where she was having a tonic-clonic seizure. There was bruising to her left orbit and also her right arm. And on examination, she was having multiple short tonic-clonic seizures, each about 30 seconds long. They put in a grey cannula and they sited an arterial line so they could do her beat-to-beat blood pressure, and they treated her fits with magnesium. They only gave her 2 grams, but they gave her 3 doses. In this case, we would normally have treated her with 1 dose of 4 grams and then started an infusion of 2 grams per hour. However, in this case, she was being retrieved from the top floor of a multi-story building, and therefore I imagine it would have been tricky from a logistical perspective. Her GCS was 9, so she wasn't as conscious as we would hoped her to be, and a GCS of 8 to 9 indicates to us that her level of consciousness is poor and she may be at risk of aspiration, and therefore we may want to consider a definitive airway, meaning intubating her. However, she wasn't intubated in this case, and I also think that's down to the logistics of the retrieval. She had a systolic blood pressure on examination of 220 to 256, so incredibly high, a diastolic blood pressure of 102 to 178, and she was treated with some IV hydralazine and giving some midazolam, which is unusual in this case, but perhaps that's all they had, due to her level of agitation, which may have been due to the amount of fitting she was having in the cerebral irritation, to a maximum of 7 milligrams in total. The communication was that the transfer was going to occur to our local hospital rather than the one she was previously seen at, and the decision was not to intubate, and instead they inserted 2 nasopharyngeal airways. On examination in the labour ward, she arrived fitting, lying on her back with a GCS of 3, a blood pressure of 200 over 102, and 2 nasopharyngeal airways in situ. In terms of A to E assessment, I want to go over how we would assess a patient like this in this extreme circumstance. And you go back to your A to E because you can categorise every aspect of the examination that you want to do, and you don't lose your focus, especially given someone who's very sick in front of you. So A for airway, we want to do a quick AVPU. So is she alert? Is she responsive to voice, pain, or unresponsive? And if you know how to do a GCS, you could do a GCS. And as I said, if they're only responsive to pain, or they have a GCS that's equivalent to 8 to 9, we need to think about securing the airway, and that's where you get your anaesthetist involved. In B, we look at her respiratory rate, we check her saturations. Do we need to support her with 15 litres of oxygen via a non-rebreathe mask? We listen to her breath sounds. Is there any signs of pulmonary edema? We give her high flow oxygen, as I said, and we would consider doing a chest x-ray. It depends on whether the fitting had seized and she was stable, and we'd certainly do a blood gas through the arterial line that was sited. We'd lie her in the left lateral position. So in C, I also think we need to focus on positioning to optimize cardiac output. And in this case, the lady was lying on her back. We need to think about BP control with hydralazine and more IV labetalol. We need to catheterize her and measure her hourly urine output because she's at risk of renal failure. In terms of IV access, we get the biggest access we possibly can, and we take some blood. So full blood count, UNEs, LFTs, clotting, uric acid, calcium, and a magnesium level. The reason being is that she'd had 3 doses of 2 grams, so a total of 6 grams, but we went on to give her more magnesium, and we would want to make sure that she doesn't get a dangerously high magnesium level whilst still trying to maintain her in a non-fitting state. We would cite an arterial line if it isn't already, and start a MECU chart, and a fluid balance chart is imperative to understand what we're giving in, which should be 85 mils an hour and no more because she's at risk of pulmonary edema, and perhaps think about doing an echo. In terms of disability, we would do a GCS and chart it. We would look at her pupils. We want to make sure that she hasn't had a bleed because she's been fitting for a long time and she's at risk of stroke. So we would check to make sure that her pupils are equal and reactive, check her blood glucose. D also stands for drug chart when I think about these things, because it's good to have a look at the drugs that she may have taken and also think about recreational drugs in many of our antenatal patients. Do her reflexes as part of disability, and also think about destination. Where is this lady going to go once we've finished treating her? And this lady would have gone to critical care. In E, you want to document any swelling or any bruising, and obviously in any other type of patient, you'd also look to see for bleeding and make sure you document that. And I always add an F to the AT assessment to add in the things that I may always forget, and I call it a flat HCG, where F stands for fluids and feeding, L stands for lines, so what cannulas or does she need a central line? A stands for aperience, so is she moving her bowels? Does she need to move her bowels? And analgesia, what medications is she on? Morphine? Does she need naloxone? Does she need anything more? And make sure we don't give NSAIDs in this case. Antibiotics, thromboprophylaxis for T. In addition, H will be head up, C would be CTG, and G is glucose control. So that's just a mnemonic that helps us have a head-to-toe picture of the patient after we've done our A to E assessment. So on arrival in our labour ward, the patient was fitting. She was lying on her back with a GCS of 3, a high blood pressure and 2 nasopharyngeal airways. We decided to take her straight to theatre with a multidisciplinary team present, meaning obstetrics, anaesthetics and neonates. And we treated her with a further 2 grams of magnesium sulphate, 50 milligrams of labetalol, and we also started a very short-acting opiate called remifentanil that you may be familiar with, and it affects the woman by helping reduce blood pressure, but it also has such a short half-life that it doesn't affect the neonate that much, although it is transferred. We started making preparation to intubate her. And we wanted to make sure that her blood pressure didn't go up as we intubated, as it commonly does. So therefore, we started all these drugs. Once we intubated her, we used rocuronium, which is a muscle relaxant, and therefore the fitting stopped. We also gave her some Keppra, which is an antiepileptic. The CTG was normal at this point, and so we considered what we should do, but we'd committed to intubating and sedating this lady, and therefore we felt that she wouldn't get any better unless we deliver the baby in the placenta, and so therefore we decided to go forward with a cesarean section. The cord gases on delivery were an arterial pH of 7.08, a base excess of -4.5, and the venous gas was a pH of 7.1 and a base excess of -6.1. And the baby came out with respiratory depression and was intubated and referred to NICU for cooling. During the intraoperative course, the lady's saturations were 93%, and we tried to aspirate the endotracheal tube, but nothing was coming out. So we considered what the causes of that could be. Because she hadn't been intubated when she arrived at our hospital, we considered that she may have aspirated, so we thought we should request a CT chest. We also were worried about pulmonary edema and didn't know what her cardiac function was like, so that was a secondary differential, but the CT chest would have shown this. We were also worried about her brain because she'd been fitting for so long, so we requested a CT head. And a subsequent CTPA showed collapse and consolidation of both her bilateral lower lobes, which could represent aspiration. Her CT head showed an area within her left parietal lobe, which could be consistent with something called posterior reversible encephalopathy syndrome, which is something that's typical of pre-eclampsia and eclampsia on a CT head, but I won't go into it in this presentation. It's a reversible phenomenon. So this is an X-ray which shows you what an aspiration pneumonia looks like. You can see the lung fields, and where the arrows are pointing is where a patient, not this particular patient, would have aspirated. So therefore, contents, gastric contents would have gone down their trachea and into their lungs. And this is a little bit about posterior reversible encephalopathy syndrome. And as I alluded to before, it's typically seen in people with eclampsia, and it includes convulsions and a combination of conscious and visual disturbance, which leads to this abnormal neuroimaging finding. And the underlying mechanism is uncertain, but it's thought to be due to endothelial dysfunction, which is typical of what happens in preeclampsia and eclampsia, which is where the lining of the capillaries become leaky. So how does preeclampsia happen? Well, it's a multi-system syndrome, and it often happens post 20 weeks pregnancy, and it's characterized by what I alluded to before, which is endothelial dysfunction and in a massive release of inflammatory markers. And 1 in 4,000 women with pre-eclampsia progress to eclampsia, which is the manifestation of fitting. You get uteroplacental ischemia, so poor placental blood flow, and that also leads to more release of inflammatory cytokines. And the cause of this is unknown, but your vessels as a result become leaky, and the high blood pressure also causes damage to other organs, such as your kidneys and your liver. And why does it happen? Well, we still don't know, but we think it might be due to developmental abnormalities of the spiral arteries in the uterus, which are much more susceptible to vasoconstriction and poor blood flow. Or it may be that these women are more susceptible to atheroma, and there is a loose association with query previous maternal infection. How do we differentiate between a woman with normal hypertension or with pre-eclampsia? Well, placental growth factor is very useful in this, and it helps us as a blood test to help discriminate between the two conditions, and that is now available in all our labour wards. So how do we treat eclampsia? Well, we have to stop the seizures, and so we treat it with magnesium sulphate, and we give it as an IV bolus of 4 grams, and then we give 1 gram per hour. In terms of the antihypertensive treatment, the aim of the antihypertensive treatment is to reduce the risk of stroke. A high blood pressure reading should be treated immediately, and we should aim to decrease that between 10 to 20 millimeters of mercury every 20 minutes. But that's very difficult to do, especially with the combination of drugs that we use, which is commonly IV labetalol and IV hydralazine. And in an emergency, it's quite difficult to titrate that so effectively. Oral antihypertensive is not a factor in this case because this woman needed immediate lowering of her blood pressure and immediate reduction of her fitting, and so therefore IV medication is the modality of choice. So how do we treat eclampsia? Well, you can give an immediate labetalol bolus dose of 50 milligrams. And then you can think also of giving hydralazine 5 to 10 milligrams diluted in 10 mils of normal saline, and you give that slowly intravenously. And you can continue these with a maintenance labetalol infusion, but you could also consider other treatments, such as an epidural if the platelet count was above 70. You could give glycerol trinitrate, which is sometimes, but sometimes that can drop the blood pressure quite significantly. Nifedipine, which is a calcium channel antagonist, or metoprolol, which is a beta blocker. And if the woman continues to fit, irrespective of the 4 gram bolus and the magnesium infusion, you can then give a further 2 grams over 5 minutes if they're less than 70 kilos, or 4 grams over 5 minutes if they're over 70 kilos. And if possible, take blood, as I said, for magnesium levels prior to the additional bolus. If any further seizures occur, then you need to think about intubation, which is what we did. And then when the woman is paralysed and ventilated, the fitting will stop. But with women who have recurrent seizures, you need to make sure that they have a CT head to rule out a cerebral event such as stroke. What do we do about fluid balance? Well, it's really important to fluid restrict these ladies because they have such endothelial dysfunction and leaky vessels. So we need to restrict their total fluid intake to 85 mils an hour. But we also need to manage their urine output, and we need to make sure that they have a urine output of over 20 mils an hour. In a woman who has less than 80 mils of urine output in 4 hours, so less than 20 mils an hour, you need to rule out other factors such as blood loss and hypovolemia, check the catheters flushed, check the woman's renal function and listen to her chest to make sure she hasn't got pulmonary edema. And then you get the anaesthetist involved and the obstetrician and proceed with a judicious single cautious fluid challenge of about 250 mils over about 30 minutes to try and prevent them from getting pulmonary edema. So pulmonary edema is a side effect or something we see, a complication of pre-eclampsia and eclampsia, and it basically is a sign of fluid overload, and their heart rate can go up, their saturations go down because they can't, their oxygen transfer is now poor. You may hear crackles when you listen to their chest, and that's something useful that you need to get used to. So start listening to these ladies' chests. If you can listen to a normal chest, then when you listen to an abnormal chest, you know what's wrong. Stop the fluids, give them high flow oxygen, check their blood gas, arrange for a chest x-ray and an echo to see how their heart is functioning, and discuss this with the consultant anaesthetist and the obstetrician and the acute response team, because this lady probably is going to have to go from your MECU to a high dependency environment or critical care. And you can consider, or they may consider, giving this woman a diuretic such as frutamide of 40 milligrams IV. So this is just the pre-eclampsia protocol of what you should do and what I've already alluded to in this presentation, just for revision's sake. So post-delivery, we need to think about what are we going to do for this lady. And they need close observation, either in MECU or in ITU, for 24 to 48 hours, because sometimes, although you deliver the placenta, they can still actually develop HELLP syndrome, as you need to carefully monitor them. You give them low molecular weight heparin and TED stockings because they're at a high risk of DVT and PE. Avoid non-steroidals such as diclofenac and ibuprofen because you don't want to make their renal function worse. Make sure that they've got good urine output, and make sure that you're taking their blood every 4 to 6 hours to check their electrolytes, their creatinine, their full blood count, clotting and LFTs, and also consider a CT head to rule out any central pathology. This chart just shows you a little bit about magnesium toxicity. I'll allow you to read it, but I think that it's something that you need to think about if you're giving multiple doses of magnesium, because magnesium toxicity itself can cause respiratory depression and cardiac arrest in some women. So if you're giving multiple doses of magnesium, it would be very prudent to take a magnesium level to make sure that they're not reaching toxic levels. So what is your role as a MECU midwife in ITU and HDU? And there's plenty of publications now that reinforce the fact that midwife presence in the critical care areas is really important, especially if a woman's moved away from the obstetric unit to a new area without their baby and in a critical condition. So it's important that you check on the woman for their maternity related needs every 24 hours. Make sure that if they're able to, that they can partake in breastfeeding or expressing milk and do breast checks, also wound checks and skin to skin if possible, and then support the HDU and ITU nurses in understanding these needs as well. And that's where you get the symbiotic learning. You can also offer a debrief to the women and their families after they've left the critical care unit. Thank you very much.